So we will spend some time here talking about retinitis, and we're generally talking about here infectious retinitis. And this is a difficult topic, uh, and the reason is because there's so many different causes, so many different pathogens that can lead to retinitis. The USMLE is not really going to expect you to know this in any great detail, and so what I address here is more than enough, more than what you need to know for the test. But I'm not going to address this in the kind of detail that you would want to know if you're studying optometry or you're studying ophthalmology as a career. So I hope if you're geared towards that, this is not going to be everything you need to know for retinitis. But this is plenty to know for the USMLE, steps 2 and 3, and if you're a primary care physician or non-ophthalmology person. So I wanted to touch on what I felt were 3 of the most important retinitis pathogens. And then we'll also just briefly talk about some other causes of retinitis that are important as well, but I think play a lesser role in the USMLE. Cryptococcus retinitis probably could fall under these important causes, though. But just as long as you get the key facts of each of these, you should be fine. The reason the USMLE doesn't touch on this too much is because this is the domain of the ophthalmologist. What you need to be aware of is how to say that, okay, this patient clearly has some kind of ophthalmologic thing going on, probably retinitis, and therefore I need to send this patient to ophthalmology. It's not going to be as difficult as you might think, because if you look at this, a lot of these retinitises are associated with other pathogens that cause other things. And so that kind of goes into what the first point I want to point out is that infectious retinitis is often a manifestation of a systemic illness. Now that can be things like cryptococcus, which can cause meningitis, it causes fever, and then can also cause the retinitis. It can be things like TB, which causes pulmonary symptoms and fever, and then can cause the retinitis, or it can be related to Candida, etc. But a lot of times with these pathogens, they cause other things besides just the retinitis. And this is also the case in babies who are born with congenital CMV or congenital toxoplasmosis or congenital syphilis. They'll have other symptoms in addition to the retinitis, and a lot of times you'll know that. So this is usually not something that just presents on its own. A few exceptions, but for the most part, retinitis is a manifestation of a systemic illness. Typically, we associate retinitis with the immunocompromised patient and the neonatal patient, and they are certainly at increased risk for retinitis for different reasons. The immunocompromised patient is at risk from different pathogens that typically don't cause symptoms in immunocompetent patients, so things there would be like CMV or I suppose toxoplasmosis and cryptococcus. Those generally don't cause symptoms in immunocompetent patients, certainly not retinitis. But then there are also pathogens that can cause retinitis in immunocompetent patients as well. So we will discuss those. And then neonates are associated with retinitis because of those congenital illnesses, those torch illnesses, toxoplasmosis, CMV, and syphilis. They're associated with this retinitis as well. Ocular symptoms for retinitis almost universally involve a blurry vision because remember, your retina is where you receive the image, and then floaters and symptoms consistent with retinal detachment, and that's because when you get an infection of the retina and you have inflammation, it's only a matter of time before that tissue starts to detach from the underlying supportive tissue. So blurry vision and floaters are practically universally associated with retinitis. Pain may or may not be present. Generally, when there's pain, it's due to infection of other ocular structures, but it does not have to be present in retinitis. Retinitis, as you can imagine, requires a rapid diagnosis and early treatment, and that's not only to prevent blindness in the eye that's infected, but also to decrease risk of infection of the contralateral eye, because a lot of times this is a systemic illness, and so if one eye is infected, the other eye can be infected as well. And if you have a patient where you suspect retinitis, even in the least, an ophthalmology referral is mandatory. So first we're going to talk about CMV retinitis, and cytomegalovirus is a dsDNA virus, and this is not associated with illness or disease or symptoms in immunocompetent patients. And so a lot of us acquire CMV, but we don't know it because we never develop symptoms. And it's estimated that almost everyone carries CMV. 90 to 100% of the population carries CMV. But, as mentioned, the vast majority are asymptomatic because we have competent immune systems. When does CMV cause retinitis? CMV can cause retinitis if it is transmitted from the mother to the fetus, and that's because the fetus does not have a fully developed immune system. And please note that the mother has to have acquired the CMV while she was pregnant. So almost everyone carries CMV, but if the mother acquired the CMV while she was pregnant, that's where the child is at risk. And then you can have CMV symptoms if you're immunocompromised. Remember, almost everybody carries CMV, but once your immune system deteriorates, then that CMV can then wreak havoc on your body. And there's other things that CMV can do besides retinitis. We'll discuss that. So the patients we really think about when we're thinking about immunocompromised patients are especially HIV/AIDS patients, transplant patients, cancer patients, and patients who are on dialysis. So the congenital CMV infection is seen in babies of mothers who had an acute CMV infection during pregnancy, and then the other symptoms of CMV infection are kind of common to those torch syndromes. They include microcephaly, petechial rash, seizures, liver enlargement, jaundice, and cataracts. In the immunocompromised patient, CMV infection can manifest as liver failure, it can manifest as colitis, it can manifest as esophagitis, it can also manifest as pneumonia. So there's different ways that it can manifest. And typically we see CMV infections in immunocompromised patients when their CD4 count goes below 50 cells per cubic millimeter. Alright, so the ocular symptoms, as mentioned before, in most retinitis, almost all retinitis, universally include blurry vision, floaters, and retinal detachment. In some cases of CMV retinitis, it can be more acute and can be a very sudden loss of vision. But typically, this is a more progressive deterioration in vision and ultimately retinal detachment. So when you have, and this will typically be, CMV retinitis will typically be the AIDS patient that is suddenly experiencing ocular symptoms. When you have a patient who has signs consistent with retinitis, you have to refer the patient to ophthalmology. And what they will do is ophthalmoscopy. And what they see on exam is typically this white granular plaque with irregular borders. And there can be hemorrhaging as well. Other things you can do to really pin down CMV retinitis, if you want to help out the ophthalmologist, is to get CMV titers, either from the blood, or the ophthalmologist would do vitreous samples. And then you should know that any patient with HIV/AIDS, if they come in with acute symptoms, you should always get the CD4 count. And this should also be done in patients who are at risk for HIV as well. Typically, patients with CMV retinitis are treated with ganciclovir, but there's other agents that are used as well. And important also to know that if a patient has been diagnosed with CMV retinitis and there's really no known cause of immunodeficiency, they're not a cancer patient, they're not dialyzing, they don't have diabetes, they don't have, we presume they don't have HIV/AIDS. You should really test them for HIV because that's probably what's behind it. If there's no other known cause of immunodeficiency. So that would be a prudent test to do in a patient who comes down with something that we would expect in an immunodeficiency, but they don't really have any existing diagnoses that would be consistent with immunodeficiency. And if they're HIV positive, of course, they should be started on an antiviral regimen. Okay, so this is this classic presentation of CMV retinitis when looking through an ophthalmoscope, and it has this this sort of granular, abstract plaque, and the normal retina reflects red, but the inflamed retina is kind of this yellowish, whitish color. And it's granular, meaning that it doesn't have a really sharp border. You can see that there's areas of very clear inflammation, but then there's these areas of developing inflammation. And also good to know that it crosses right through where these veins are. And that's going to help you distinguish this from something else that can cause retinitis in a immunocompromised patient, and that would be varicella zoster virus, or herpes simplex virus. So here, again, you see this sort of granular appearance crossing through the veins. And there can also be some hemorrhaging as well. Okay, Toxoplasma retinitis. So this is a retinal infection by the parasite Toxoplasma gondii. And exposure is usually due to handling cat litter, but can also be due to undercooked meat and eggs or unwashed vegetables. So in immunocompetent patients, again, this is not something that causes a problem because this is easily reined in by the immune system. However, you can get this kind of flu-like syndrome on initial exposure while the immune system is mounting a response, and that's going to be fever, muscle aches, swollen lymph nodes, maybe a hepatosplenomegaly, but generally this is subclinical. In immunocompromised patients and in children born to mothers who acquired toxoplasmosis during the pregnancy, you can get ocular symptoms. So in immunocompromised patients, the ocular symptoms are going to be decreased visual acuity and floaters, or retinal detachment possibly. They can also develop encephalitis or dermatologic symptoms, so some of the non-ocular symptoms. But the ocular symptoms are going to be just very typical to retinitis. With the congenital syndrome in babies to mothers who acquired toxoplasma during the pregnancy, they'll have some of those typical torch features like low birth weight, premature birth, jaundice, hepatosplenomegaly, cataract, neurologic deficits, mental retardation, and so forth. And then the ocular symptoms can be present at birth, but in some cases, the child doesn't develop ocular symptoms until adolescence. So ocular symptoms might not develop until much later. For diagnosis, whether this is the immunocompromised patient or the baby with suspected congenital toxoplasmosis, ophthalmoscopy, referral to an ophthalmologist is going to be necessary to visualize the lesion. Typically, what we see with Toxoplasma retinitis is this white fluffy lesion, which is the active retinitis, and a lot of times this is accompanied with areas of scar tissue, which is where the Toxoplasma, where the retinitis was, but has since died and has left a scar. So you'll see these white fluffy lesions with these scars, and these scars are usually a little bit darkened, kind of grayish, blackish, greenish in color. And then there may be vitreous haze, and that haze is just debris in the vitreous fluid. Of course, if you suspect Toxoplasma retinitis, then you should get Toxoplasma titers, and they will determine whether the patient has an active infection. And I'll just add IgG and IgM are usually the antibodies that we're looking at, and IgG is a chronic infection. IgM is would determine that the patient has an acute infection, an active infection. Okay, so for diagnosis, as mentioned, you're going to need to refer to ophthalmology, but it's always useful to know that you can get titers for Toxoplasma. For treatment, patients with acute toxoplasmosis are administered pyrimethamine and sulfadiazine. We'll also give them corticosteroids to reduce the inflammation. In addition to this, we also give them folinic acid. Pregnant women who test positive for Toxoplasma, and we always test pregnant women when they are diagnosed as pregnant, we always test them for Toxoplasma. If they have an acute toxoplasmosis, so if they have the IgM, we give them spiramycin to reduce transmission to the fetus. And then in immunocompromised patients, especially patients with HIV/AIDS, we will give them pyrimethamine sulfadiazine as prophylaxis. And this is also effective as prophylaxis against pneumocystis jirovecii pneumonia. Okay, so here's the Toxoplasma retinitis, and this is the active inflammation here that is coming out as sort of yellowish in color. And then this is the old scar area. Another one right here. Kind of looks like a bomb exploded in the eye. And here's another one. So there's your scar and your active inflammation. This is right on the macula. Okay, and then Candida retinitis is the most common fungal infection of the eye. This is seen in newborns who were exposed to Candida in the birth tract, and also in patients with specific risk factors. So patients with who have a history of IV drug abuse, any recent major surgery, any recent sepsis, probably due to the antibiotics that they were given, patients with indwelling catheters, dialyzers, cancer patients, and diabetics. And then, of course, newborns with mothers that have active Candida in the birth canal. Symptoms, again, are very typical to retinitis: decreased visual acuity, floaters. These patients typically have pain because Candida also affects the anterior structures of the eye. And so this will present as a red eye a lot of times. And then they can also have photophobia too. So for diagnosis, again, you're going to be referring this patient to an ophthalmologist. They'll visualize the lesion, and the way this typically presents is that white fluffy mass, and it's usually it looks like a headlight to a car in fog. And so it's what that fog is vitreous haze, and the headlight is that white fluffy mass. And the way we treat Candida retinitis is with amphotericin B and flucytosine, but other agents can be used as well. So here's anterior uveitis. This is an inflammation of the anterior structures of the eye. So what you most prominently see here is the red eye. And then what you'll also note is this collection of sort of whitish material along the bottom of the eye, or bottom of the iris area. So you see it there, and a little bit there. So here's Candida retinitis. Note that you can't see these the arteries and veins. You can't see them as sharply because of that vitreous haze, and that the vitreous haze is just debris in the ocular fluid. So again, here, very, very hazy. But you've got your lesion right here. And this is typically just diagnosed on exam by the ophthalmologist. Okay, so some other causes of retinitis. So these are two causes of retinitis that are associated with herpes zoster virus as well as varicella zoster virus. So the first one is acute retinal necrosis, and this is a disease of young, healthy adults. And it's caused by herpes zoster or varicella zoster, and these patients will present with acute typical retinitis symptoms, so decreased visual acuity in one or both eyes, floaters, possibly symptoms consistent with retinal detachment, and on exam they will have this patchy white necrosis, usually along the peripheral areas of the retina, and a lot of times you see these little holes. And what these holes are, I put these in quotes, these holes are just area of normal tissue. And this is in the peripheral retina, and it progresses towards the posterior pole, which is that where the macula and the optic nerve are. This is treated with acyclovir and corticosteroids. However, this has a really, really, really bad prognosis. So I'm going to just show you some pictures right now while it's fresh in your mind. So notice that this is along the peripheral retina. And these holes are just these areas of sort of normal tissue. So it kind of skips over these areas. So here, a little bit maybe here. Can't tell if that's hemorrhaging or it's a hole, but another one here. Again here, this is looking a little closer, but this is normal, relatively normal tissue. Okay, so the other one that is associated with zoster is porn. And by porn, I don't mean the dirty material, I mean progressive outer retinal necrosis. And this is a herpes zoster or varicella zoster retinal infection that is seen in immunocompromised patients. And this pretty much is similar in all means to acute retinal necrosis, but the appearance is a little bit different. So this generally doesn't have those holes. It's usually a homogeneous necrosis, and it has what's known as a cracked mud appearance. And that cracked mud appearance is due to sparing along the veins. And that stands in contrast to the CMV retinitis that, remember, I mentioned earlier that we were going to get to, where the CMV retinitis kind of goes right through those arteries and veins. It doesn't spare along there. The progressive outer retinal necrosis has sparing along the veins. And that is going to be a helpful way to differentiate this from the CMV retinitis, which immunocompromised patients, especially HIV/AIDS patients, are at major risk for. So this is treated, because this is also viral, this is treated typically with ganciclovir and foscarnet. And this can be administered either intravenously or intravitreal. But this also has a poor prognosis. So let's see what this looks like. So this is progressive outer retinal necrosis. And what I want you to note is the extreme amount of inflammation, as well as the hemorrhaging, but also that there's this sparing along these veins. So whereas with CMV retinitis, the inflammation just kind of went right through the veins, it covered up the veins, here you can still see the veins and arteries. And that's what gives us this cracked mud appearance. So this is cracked mud here, or like really dry brownies. So look in here, you see that the inflammation does not go through the veins, the venules, or the arterioles. They're sparing. See this sparing here along the venules and the arteries? I can't really tell what they are, if they're arterioles or venules, but they're sparing here. You got inflammation along here, which is white, and sparing, which is red. And the sparing is along the venules and arterioles. So finally, some other causes of retinitis. There's cryptococcal retinitis, and this is important to know about. I should have probably included this at the beginning because cryptococcal retinitis is commonly tested. But you really don't need to know a whole lot about it because they generally almost always present in very sick AIDS patients, and it's in many ways very easy to predict when it's happened because it's an AIDS patient who's coming in with meningitis-like symptoms or an AIDS patient who's coming in with ocular symptoms. So this can be either cryptococcal retinitis or cryptococcal meningitis. A lot of times, though, it's both happening at the same time. And this is caused by a fungus, Cryptococcus, and this is treated with amphotericin B and flucytosine. Syphilis retinitis is considered a manifestation of neurosyphilis, and so the patient can have other coexisting neurologic symptoms or symptoms of tertiary syphilis, which would be cardiovascular. The history of the patient that you'll get on a test question likely includes a patient with high-risk behaviors such as multiple sexual partners, IV drug use. The diagnosis is going to be with the rapid plasma reagent, RPR, and if that comes back positive, then you'll get the FTA antibodies. And then the treatment is going to be the very same treatment you give for neurosyphilis. And so that's high-dose penicillin G administered intravenously for 10 to 14 days. You can also get congenital syphilis, and that can also cause retinitis, but we're not going to go into that. Remember, I told you this is very complicated. Lots of different things can cause retinitis. I'm just going over some of the basics. And then finally, TB retinitis. This is a manifestation of tuberculosis, obviously. So the way we're going to diagnose this is the same way we diagnose tuberculosis in any other patient. Start with the tuberculin skin test. You'll have 10 to 15 millimeters of induration. That's going to be a positive exam. That's followed by chest x-ray. And then we will give the patient the standard treatment for TB. And that's, we've got 5 drugs that we typically give them. That's rifampin, isoniazid, ethambutol, pyrazinamide, and streptomycin. Usually we give them 3 or 4 out of the 5 for about 9 months. And that will treat the TB. Okay, so I didn't talk about every single thing that can cause retinitis in every single patient, but I think if you know this stuff that I included in these slides, you will be more than set for the USMLE and most of the things that you're going to see in clinical practice. But remember that when you see retinitis in a patient, well, it is great to know as much as you can about the patient and do as much clinical testing as you can. It's going to be the ophthalmologist that's going to be doing the visualization of the retina, and it's going to be the ophthalmologist that's going to come to the conclusive diagnosis of what type of retinitis it is. So your job is to get as much information as possible in your history and physical, and to also know when to refer, to do that referral, and to know when to refer, because that's what's most important. As long as you refer the patient to the ophthalmologist, they can take care of this. This is something they see quite often.